have Ronit Satchi Fainaro with us. She is head of the Cancer Angiogenesis and Nanomedicine Lab and chair of the Department Physiology and Pharmacology at Sackler faculty in Tel Aviv, yes. So we are looking forward to your intervention to identifying molecular signatures.
Thank you, Beat, and thank you for inviting me to this wonderful conference. I learned a lot, and I'm really glad to be here. And I'm glad that the brave ones survived and stayed that late today, so we can share some of the information and have some new collaborations ongoing with these ideas. So I will focus today on melanoma brain metastasis, but I will give it more as an approach to tumor dormancy in general. And this started when the NCI had these provocative questions, when one of them really initiated my curiosity: what molecular or cellular events establish tumor dormancy after treatment, and what leads to recurrence? And this was very interesting for me because we know that there are several manifestations for tumor dormancy. The first can be the primary tumor, a period in the beginning when a primary tumor, before it escapes and recruits the vasculature and the microenvironment, it stays as a 1 to 3 millimeters in size, avascular in situ carcinoma, very small tissue, and only then something happens, and that something is what we are looking for, and it starts recruiting the microenvironment, growing in size, and then it starts sending some tumor cells intravasating into the vasculature, circulating, and then extravasating at the distant site that is very different from the original site where it came from. And then, again, it stays for a week, a month, 20 or 40 years as a dormant metastatic in situ carcinoma, and then the whole process starts again. The third manifestation is very interesting for us and very relevant to this conference also. Many people talked about image-guided surgery or some other recurrent diseases, and this is speaking mainly about minimal residual disease, where we see that following surgery or treatment, we have several cells, tumor cells, that remained in the tissue. The surgeon was unable to see them. He didn't have those bionic eyes yet, and the bionic that Alon spoke about yet. And they remain there, and again, they remain as dormant. And when I talk about tumor dormancy, I'm not talking about cellular dormancy. This is not G0, quiescence, or senescence, but rather we are talking about a tissue dormancy. This is a tissue that is 1 to 3 millimeters in size. It is not vascularized yet. It is metabolically active, so when I get these tissues, the FFPEs from these tissues, I can see that it stains for proliferation and apoptosis, so there is some balance between them, but it remains at this dormant site for a long time. So I know it's a late hour, but I would like to have you a little bit opening your minds and think more philosophically about this, especially the metastatic dormancy. And I'm thinking, what identifies those cells? Could it be more of a tourist kind of character? Did they leave the primary site, arrive to that metastatic site that maybe yes, maybe not, had this niche prepared for him to come and host him in a very different cellular environment? Or maybe they are acting as ambassadors, meaning that they are coming from the primary site and they have all those receptors, all these markers that are similar to the tissue where they come from. For example, if they come from the breast and they go to the brain, do they still continue to show their markers, their progesterone and estrogen receptors? Or maybe they become more of a refugee type, like the triple-negative breast cancer, that they have no identification whatsoever, and they try to be under the radar, mainly the immune radar and the radar of those microenvironment cells that are in the distant site and tissue. So, looking at melanoma brain metastases that come from, for example, the skin, we know that melanoma is the leading cause of skin cancer-related death. We know that melanoma is highly metastatic and frequently metastasizes to the brain. the brain metastases result in death in nearly 95% of patients with a median survival of less than 1 year. And 75% of post-mortem analysis, we know of melanoma patients, present those tiny dormant brain metastases. These are micrometastases that were not detected earlier. Incidence is rising, and it's mainly rising because of the immunotherapies and the BRAF and MEK inhibitors that are working wonderfully in debulking the tumor, but still, the longer we live, we see more recurrence, and when they recur, they become way more aggressive, those tumors, and at different metastatic sites, especially in the brain. And last but not least, despite the clear clinical implications, the mechanisms underlying survival and colonization of metastatic melanoma cells in the brain are still poorly understood. So we're looking at those cells that are hosting, the stromal cells that are hosting the melanoma cells that arrive in the brain, and you can see clearly that we have a whole variety of different cells. Some of them are the astrocytes, the CD4, CD8 plus T cells, neurons, microglia, endothelial cells. Each one of those stroma cells have physiological roles that we won't go into them now, but they can be very helpful for metastatic cells that arrive to the brain. This is not true only for melanoma, breast and lung. We see them also very extensively in the brain as metastasis. But somehow it doesn't make sense, because we know that from all the organs in the body, and there were several talks here today and yesterday about the blood-brain barrier, this is the less trivial site where some tumor cells that are circulating, imagine that they are in a very, like a river, they will stop in the place where it's the most difficult for them to stop, and then extravasate there from those very tight blood vessels of the blood-brain barrier, and there they will sit in a very foreign environment and start creating those metastases. So we would like to know what is the mechanism by which the stroma cells facilitate this metastatic growth. So we had an hypothesis, and the hypothesis was that we have this primary melanoma in the skin. At some point, it starts having some tumor cells, some melanoma cells that are circulating in the blood circulation, in the bloodstream. Then what happens is that we get some, they are all the time secreting cytokines, pro-inflammatory cytokines, chemokines that are going everywhere while they are circulating, but some of the cells, of the stroma cells in different organs, start listening. They start getting those signals, and for example, the astrocytes, they are becoming activated, and we can see it by GFAP activation. Then they start responding by this activation, and we see that they start secreting in response to the blood vessel, to the endothelial cells, to become hyperpermeable. So now the vessels, those very tight blood-brain barrier vasculature, becomes leaky, and allows the melanoma cells that get the signal from those cytokines to come and extravasate from the leaky vessels, having this pre-metastatic niche preceding the seeding and colonization of those melanoma cells, entering that vicinity that is neuroinflammatory already because of the cytokines that were secreted, and now they extravasate. We see the activation not only of astrocytes, also of microglia, the endothelial cells become, the vasculature becomes very leaky, and we have again those tiny dormant tumors that sit, melanoma tumors that sit for a while. It can be for a shorter or longer period until they start to recruit their own blood vessels, angiogenic vessels, and start growing and becoming a little disease. So this is the hypothesis, and the way we wanted to address this was by first creating a model of primary and spontaneous brain metastases. We created models of patient-derived xenografts, of murine cell lines and transgenic mice, and human cell lines in mice. We wanted to see all, because some are immunocompetent, some are immunodeficient, so we wanted to have the whole picture. And we ran some omics, RNA-seq, proteome profiler of the condition media, where when we co-cultured the melanoma cells together with those stroma cells from the brain, we wanted to see what are the cytokines that are the ones that are overexpressed, and now preparing the niche for the melanoma to start growing in the brain. And once we had some characterization and having some cytokines as targets. We wanted to see if they are druggable targets. We created some functional assays and to validate that target. For example, if we have a cytokine that is overexpressed once the melanoma cell arrives to the brain by secretion of a cytokine from an astrocyte that became activated, we wanted to see if we block it by siRNA, neutralizing antibody, CRISPR. Do we get the regression to the primary? Do we get a regression of the melanoma metastasis in the brain? And once we do have it, if, for example, we used siRNA, as we spoke about it in this conference, we have the tools to encapsulate and trap, conjugate, or complex it with a nanocarrier, and then together with the profiling of the BRAF mutations, for example, we would like to have the BRAF inhibitors directly arriving just to the melanoma metastasis and not attacking all the body. At the same time, combining two, like BRAF and MEK inhibitors that we know that were very successful in the clinic, but had their own issues of resistance and becoming more aggressive, we see them that we can put them together on one polymeric nanocarrier, like polyglutamic acid in this case, and then target them together and testing them on in vitro, in vivo in mice, using all these models are M-Cherry labeled, so we can use non-invasive intravital imaging to follow the tumor progression and metastasis colonization and hopefully move into men. So we have the models, as I said, murine, human, and patient-derived, and we see that indeed we get in our models GFAP activation, meaning that the astrocytes are activated once the melanoma cells from the primary tumor arrive to the brain and start activating the microenvironment. IBA1 activation, meaning that the microglia is also activated. We see CD31, very high staining, so there is new vasculature, and the vasculature that is there is very leaky, as we can see here by Evans blue, and we quantified it by microscopy and by leakiness of the Evans blue that binds to albumin, making it a 70,000 macromolecule, 70,000 Dalton macromolecule. So we know that we are recapitulating the clinical setup. So we have the tools, and now we decided that maybe we should do it the other way around, because when we had some neurosurgeons joining the lab, they said, let's start from the human, from the surgery room. We took a chunk of the melanoma brain metastasis, we implanted it in the mouse and it worked great. We got several nanomedicines developed, but it takes a very long time. It takes about 6 to 9 months to have 60 to 80 mice. And for that, we thought that we had to think out of the box to have a very rapid screening. So we started with getting the notification first from the neurosurgeon that there is a surgery coming up, then getting the MRI or the CT slides, doing the image analysis, and then 3D printing the tumor, recreating the tumor as we did here. This is a bit of a sickly joke of the chemical engineer that is working on this project. She made an ear. Some of you might remember the ear from Bob Langer. Now she made the tumor ear. Then the red is the M-Cherry labeled cells. So we can now have 100 mini tumors that are similar to the original tumor that was in the patient, and using microfluidics, we have we have here the blood vessels that are created because we have all the stromal cells and the endothelial cells originating from the tumor. So from every tumor, we take and do all the FFPEs, isolated lines, 3D printing, and the animal models, and we combine those targets that are validated on those models on different polymers using a dendrimer, for example, a polyglycerol dendrimer that is fully aminated to a complex with siRNA of a certain cytokine, or a polyglutamic acid that is a linear or hyperbranched with bound to BRAF and MEK inhibitors like selumetinib and dabrafenib, or a micellar structure or a PLGA nanoparticle where we entrapped different MART1, MHC1, and MHC2 peptides that we can load them together and have the dendritic cells being activated and activating the T cells, cytotoxic T cells, arriving to the tumor. So this is for prevention. We have a mannose that is targeting the dendritic cell, PLGA nanoparticle, that inside it we have two MHC1 and MHC2 partial MART1. MART1 is the marker for melanoma cells, nanovaccine. This is for prevention. We use for intervention a polyglutamic acid that is bound to the brafenib and selumetinib, a MEK and a BRAF inhibitor, or in PLGA and trapped. So we have the two molecules that we are comparing tete-a-tete between them. And last but not least, this is the most difficult one, using regression trial, meaning that we take our either polyglutamic amphiphilic conjugate having a alkylated and aminated particle that complexes the siRNA of those cytokines that we found to be involved in the interactions between the melanoma cells and the stroma cells in order to sabotage these interactions and interrupt them, so not to allow them to create this very permissive microenvironment that will allow the melanoma cells to arrive there. Very good. So, to that, we can, of course, combine with the existing immunotherapies, and a combination that we try to combine together with our nanovaccines is an OX40 and PD-1 antibodies. I won't go into it, but I'd rather tell you about the PLGA nanoparticle that we entrap together with this MART1 MHC1 and MHC peptides. The size was around 170 nanometers. We found it to be the best and the optimal size to activate the dendritic cells using the mannose that is decorating the PLGA nanoparticles, which targets the dendritic cells. And you can see here that it indeed binds to dendritic cells. We see that we do the Hawk immunization to mice. And it's with a psi-labeled nanoparticle. We see that the lymph nodes, it arrived to all the lymph nodes very nicely. It binds better when it has the mannose rather than without the mannose. We see that when we take the splenocytes, we isolate them from spleens of mice that were vaccinated, we get all these cytokines increasing and overexpressing. And these cytotoxic T cells now, when we put them together with the melanoma cells, we see an increased apoptosis as shown here with the green labeling. I will move to the last in vivo slide, and here you can see how the combination of all of this together worked very nicely in a mouse with being safe. We didn't see any toxicity. We didn't treat them for very long, but for about 70 days, we could see an enhanced prolongation of survival, as you can see here, compared to those that were only vaccinated or only had a combination of the PD-1 and OX40, that is a combination that stimulates the cytotoxic T cells, and on the other hand, stop the brakes. It blocks the immunosuppression with the PD-1. So it seems that this combination is very promising for melanoma brain metastasis, and we indeed get CD4 and CD8 cells infiltrating, and this is one of the huge problems in also pancreatic cancer and others, to get those infiltrating and inhibiting the tumor growth. So I will move with the cytokines, just tell you that we inhibited those cytokines, and they arrived there specifically via the hyperpermeability in the blood vessels. All the melanoma tissues that we tested had very high cathepsin B. Cathepsin B cleaves the polyglutamic acid, then releases the combination of the drugs, the BRAF inhibitor, the MEK inhibitor, and finally we can see that combining all these three by prevention, intervention, or regression trials, we indeed got the whole together accumulating in brain metastasis. Here marked in with the M-cherry and Cy5 labeled conjugate, we see them colocalizing in the brain following systemic activation. So to summarize, you can see these are all the points for intervention that we worked on. I'm sure we can discuss those later with other opportunities that you described here. This work has been done with biologists, MDs, engineers, and chemistry majors, and it's a pleasure to work with all these people coming from different fields. And what I see here as well is when you drain the water from the ocean, you'll find out that all the islands are connected. Thank you very much.
Thank you very much. Question. Yes, Jose.
It's a second? Okay. So thank you very much. You were asking us to think of the problem and to think of why the cells move to the brain. And you have all the pictures with the endothelial cells very leaky. But it doesn't need to be like that. Actually, the migration through the endothelium is not always through a paracellular part. Sometimes it's through the cell.
And we tested it.
And I wonder, for instance, if maybe this will be difficult. Maybe we will need a little robot to go and to pick up the cells. But could not be that the cells that they are circulating, that they abandon the primary tumor, they have maybe some different surface molecules that may interact with the endothelium and go through this kind of invadosome and to pass through. We will not see, because maybe when they are in the metastasis, they lose these cells. So the phenotype that you see at the beginning and at the end probably is the kind of static, but in the way to go there, maybe they have some molecules that will allow this transmigration. It will be difficult to catch, but you have GFP and I don't know. So.
But it is possible. And indeed, you are right. It's actually more interesting than that. We saw some molecules that were actually increasing. For example, alpha-V beta-3 integrin was increased in expression from the primary through the circulating melanoma cells. And then when it arrived to the site, already following the activation of the endothelial cells, that I agree, we saw that by electron microscope in work that I did with Hal Dvorak about 10 years ago. We did see that those endothelial cells that are activated, it's transcytosis and in between the cells, but they are more leaky. Either if it is between the cells or through the cells, they are more leaky. So we see that penetration, and now when they reach there, they don't need to migrate anymore or to be more adhesive, and at that point they sit and they lose the alpha-V beta-3, for example. This is one of the markers that we saw, so you are correct.
Thank you very much, Ronit.
Thank you.
Great. Now Lou Barlow.